Pancreatic tumors divide into two distinct categories based on their tissue of origin: endocrine tumors, which secrete hormones, and exocrine tumors, which arise from the ducts and acini. Exocrine malignancies are far more common and account for the vast majority of clinical morbidity. Within the exocrine category, pancreatic ductal adenocarcinoma, or PDAC, is the single most common carcinoma of the pancreas. It originates directly from the ductal epithelium, developing predictably from an in situ precursor lesion known as pancreatic intraepithelial neoplasia, or PANIN. This maps the molecular pathogenesis of PDAC. The sequence begins with a first hit, a mutation in the KRAS gene, the most frequent oncogenic event. Next, an intermediate alteration in the CDKN2A gene compromises regulation, paving the way for the final hit, a p53 tumor suppressor mutation, locking the cell into malignant growth. This mutational sequence is driven by a combination of acquired and environmental risk factors. Smoking, obesity, diabetes mellitus, and chronic pancreatitis accelerate the process. There are also specific genetic drivers, such as PRSS1 causing hereditary pancreatitis and SPINK1 driving tropical calcific pancreatitis. Beyond standard risk factors, patients with specific genetic syndromes face a markedly higher threat. Peutz-Jeghers syndrome, driven by a mutation in the STK11 gene, severely increases pancreatic cancer risk. The BRCA2 mutation also shows a strong association, far more so than BRCA1. By the time this genetic sequence yields a tumor in the exocrine ducts, the mass is large enough to block the primary drainage system of the pancreas and biliary tract, triggering catastrophic structural blockages. The location of an exocrine tumor dictates how it harms the patient. Cancers occurring within exactly 2 centimeters of the ampullary opening are grouped together as periampullary cancers. This tight geographic boundary includes carcinoma of the pancreatic head, ampullary carcinoma, distal common bile duct cholangiocarcinoma, and duodenal adenocarcinoma. Because they all choke the same critical anatomical intersection, they share a uniform clinical presentation: progressive obstructive jaundice, significant weight loss, and pain. Clinicians refer to this triad as surgical jaundice. Ampullary carcinoma presents an anatomical exception to this study progression. Because the tumor sits directly on the ampulla, the friable malignant tissue can periodically slough off. This briefly relieves the obstruction, resulting in a waxing and waning pattern of jaundice, paired with melena as the sloughed tissue bleeds into the digestive tract. This side-by-side schematic illustrates the mechanical logic behind Courvoisier's law. If a patient has obstructive jaundice and a palpable gallbladder, the blockage is rarely caused by gallstones. Malignant distal biliary obstruction causes the biliary tree to dilate, stretching a healthy gallbladder until it is palpable. Conversely, chronic gallstone disease causes repeated inflammation, leaving the gallbladder fibrotic, contracted, and unable to distend. There are exactly 4 strict exceptions to Courvoisier's law: a primary common bile duct stone, a double impaction of stones causing both mucocele and jaundice, oriental cholangiohepatitis linked to liver flukes, and Merizi syndrome. Clinical signs and palpation provide only a baseline suspicion. Confirming the exact nature of the structural blockage requires specific radiologic mapping. Contrast-enhanced computed tomography, or CECT, of the abdomen is the absolute investigation of choice. While it may miss early, subtle lesions or microscopic peritoneal metastases, it is central to diagnosing the tumor, staging it locally, and assessing whether it can be surgically removed. This diagram demonstrates the classic double duct sign. A mass creates a central pinch point, causing simultaneous upstream dilation of both the common bile and pancreatic ducts. Other historical markers include the Frostberg reverse 3 sign and duodenal C-loop widening on plain X-ray. Pancreatic cancer is treated primarily as a radiological diagnosis. Taking a physical tissue sample risks seeding the tumor and is reserved only for cases of diagnostic uncertainty. When necessary, transgastric EUS-guided fine needle aspiration cytology is the preferred method. The tumor marker CA19-9 provides supplementary data. It serves as a predictive and prognostic marker and helps identify candidates for staging laparoscopy. However, it lacks specificity, as it also elevates in cholangiocarcinoma and gallbladder cancer. confirming the presence of a mass is only the initial step. The critical clinical challenge relies entirely on using this imaging to calculate the precise hemodynamic boundaries of the tumor. This cross-sectional vector map illustrates the Vardachari criteria for operability. Resectable disease has zero vascular involvement, mandating upfront surgery. Borderline resectable involves limited contact, like SMA abutment under 180 degrees. Unresectable disease is defined by encasement over 180 degrees, requiring strictly palliative management. There are also absolute contraindications for resection that immediately categorize a case as unresectable, regardless of vascular geometry. These include peritoneal metastases, malignant ascites, and liver metastases. This rigid vascular and metastatic criteria acts as the ultimate arbiter of a patient's treatment pathway, determining exactly who survives to reach the operating table. Tumors confined to the body or tail of the pancreas can be removed via a straightforward distal pancreatectomy. Hahowever, tumors in the pancreatic head and periampullary region demand a highly complex pancreaticoduodenectomy, universally known as the Whipple procedure. Looking at this overhead map of the upper GI tract, we can see the exact anatomical components excised during a standard Whipple. The surgeon performs a cholecystectomy, transects the distal common bile duct, removes the stomach, and excises the pancreatic head along with the duodenum. A critical step in this massive resection is developing the precise surgical plane between the pancreas and major mesenteric vessels, the tunnel of love. After excision, the digestive tract is rebuilt via 3 anastomoses: a hepaticojejunostomy, a gastrojejunostomy for food passage, and a pancreaticojejunostomy. The radical altering of the digestive tract makes delayed or impaired gastric emptying the most common postoperative complication, particularly in conventional Whipple procedures where the pylorus is removed. A pancreatic fistula commonly presents on postoperative day 2 or 3, identified by turbid, amylase-rich drain output leaking from the pancreaticojejunostomy. While fistulas often settle, an anastomotic leak resulting in sepsis remains the most common cause of death following the operation. The Whipple offers a radical structural solution to a structural disease, but it is useless against a different class of pancreatic tumors, those that kill not by physical obstruction, but by hijacking the body's biochemistry. Pancreatic endocrine tumors, or PETs, arise from the endocrine islet cells. Instead of causing silent blockages, they actively secrete hormones, driving systemic biochemical syndromes. Insulinomas are the most common PETs, arising from beta cells, and 90% are benign. They present classically with Whipple's triad: fasting hypoglycemia, blood glucose under 50 mg per deciliter during symptoms, and rapid relief after glucosammonistration. Elevated C-peptide levels are crucial here to confirm endogenous insulin production and rule out exogenous injection. Passerow's triangle defines the boundaries where gastrinomas form: the cystic and common hepatic duct junction, the pancreatic head-neck junction, and the D2-D3 transition. D1 is the most common site. Tumors outside this zone are larger, more aggressive, and carry poorer prognoses. Gastrinomas drive Zollinger-Ellison syndrome. Massive acid production prevents the activation of pancreatic enzymes, causing diarrhea, and yields multiple recurrent peptic ulcers in atypical locations like the jejunum. Diagnosis requires a fasting gastrin level above 1,000 picograms per milliliter, or a positive secretin test. Alpha-cell glucogenomas present with the 4 Ds: diabetes, dermatitis, deep vein thrombosis, and depression. VIPomas produce excess vasoactive intestinal peptide, causing Pulving-Nabiudic-A syndrome, watery diarrhea, hypokalemia, and achlorhydria. Somatostatinomas predictably cause steatorrhea, diabetes, and gallstones. Because these tumors are functionally loud but physically small, they require targeted molecular localization, like somatostatin receptor scintigraphy. Finally, the pancreas can harbor cystic neoplasms. The clinical imperative is differentiating these true tumors from benign inflammatory pseudocysts through specific radiological calcification patterns. This CT simulation shows a serous cystic neoplasm in an elderly patient. Note the multiloculated sunburst appearance with central calcification. Contrast this with the mucinous cystic neoplasm in premenopausal females, defined by a clear center and peripheral eggshell calcification. IPMN is diagnosed via ERCP using the Ohashi triad, a dilated ductal system and thick mucin extruding from a gaping fish mouth ampulla. Mastering pancreatic pathologies requires moving between three distinct analytical frameworks. You must track the mutational breakdown of exocrine tumors and calculate the rigid hemodynamic geometry that dictates surgical operability, and trace the systemic biochemical fallout of endocrine anomalies. Evaluating all three ensures accurate localization, precise staging, and the correct path to intervention.